My name is Corey Wiggins. I'll be moderating this panel this evening. Our panel is entitled Increasing Minority Participation in the Affordable Care Act. As we all know, for the past 4 years, there's been a lot of conversations both in this state and nationally about the Affordable Care Act. And what we're going to do today is spend some time sort of unpacking a little bit of that conversation, both from a historical standpoint all the way up to where we are today, and also what are some things that we can be looking towards to do in the future. Today we have a very distinguished panel. What I'll do at this time, distinguished, right? So what we'll do at this time is just do a brief introduction, read a brief introduction for all our panelists, and then we'll sort of jump into everything. So to my far right here, we have Dr. Luella Tony Lewis, who has spent her life committed to social justice. From an early age, she was taught by 2 generations of union leaders in her family. She was taught in terms of the highest form of leadership and that all humans deserve justice, dignity, and respect. With their support, she pursued a career in social justice through medicine, earned her bachelor's degree in sociology and medical doctorate from Georgetown University in Washington, D.C. As a healthcare reform movement intensified in 2008, Dr. Lewis continued to work to raise the voices, of healthcare providers and communities that they serve. Because of this work in 2010, with the support of her family, friends, patients, colleagues, and SEIU President Mary Kay Henry, she was appointed chair of SEIU Healthcare, the largest division in SEIU. She currently serves SEIU in this capacity on the board of SEIU as International Vice President. On your right here, we have Dr. Demetri Marshall, who's a graduate at University of Mississippi Medical School and also holds a Master in Public Health. He's a longtime community activist, past president of the Provisional Government of the Republic of New Africa, and resident of Claiborne County, Mississippi. Dr. Marshall served as a medical director and family physician at a community health center in Port Gibson, Mississippi for more than 25 years. Thank you, Dr. Marshall. And last but not least, to my near left here, we have Dr. Carl Reddix, who's an OBGYN here in Jackson, Mississippi. His practice is principally focused on providing health care in jails and prisons. Dr. Reddix also holds an MPH in public health policy. Thank you, Dr. Reddix. So as you can see, we have a lot of diversity in this group in terms of experiences and work and potential work. Sort of jumping right in, what I would like to do is start off with RIMS. And RIMS, if you could for us, as we think about the Affordable Care Act, in terms of increasing access to health care throughout the United States, could you sort of parallel that with us or give us a historical context to think about access to care from your past work and sort of bringing us up where we are today in doing this work around increasing access to care?
Well, it's interesting getting an assignment at this moment. I mean, Mississippi was one of the last states to implement the Medicaid program in 1970. And when it did so, it did it in a very minimal way that excluded people and narrowly limited people's access. We were able, through advocacy and a couple of lawsuits, to get some expansions. For example, initially only welfare children, not welfare mothers, were on Medicaid, and we had to file a lawsuit in order to get the mothers included so they could get health care. We worked tirelessly with community groups, telling the stories of people who have need of adequate health care, to use it as a way to expand Medicaid, so that today it has grown to over 700,000 people on the Medicaid program. And it is critical. I mean, the fact is, most hospitals couldn't do without it. I mean, without it, they would go under. And people who have money wouldn't have access to health care either if there wasn't Medicaid. Because the hospitals would dry up and the doctors would move away, and pretty soon there wouldn't be any way to get health care at all. So the publicly sponsored and paid for health care has been terribly important in the state of Mississippi, although the politicians seem to ignore that fact. So we've had to fight step by step to get expansions. Now we have the Affordable Care Act coming in, and that has some real benefits that I'd like to reference. Since January, when it was fully implemented, we have finally done away with 9 years of face-to-face interview requirements to get onto Medicaid and to maintain your Medicaid annually. And we've been struggled against when Haley Barbour put that thing in, but we've been unable to do anything until the ACA came in and did away with it specifically. We were the only state in the nation that used that method. And as a result, 25,000 children got on Medicaid since the 1st of January because they didn't have to go through this stupid process anymore. We have simplified the application process so that people can apply. And we've added 25,000 children, almost all of them black, and 11,000 adults. The health insurance marketplace went through political tiff between the insurance commissioner and the governor. The insurance commissioner had done a good planning process and it involved a lot of people in that process. And I think was going to have a decent marketplace set up. But the governor vetoed it and got it canceled, and we had to go with the national health insurance marketplace, which had its own problems, as everybody knows. But regardless of those problems, 61,494 Mississippians have signed up for affordable health insurance through that marketplace. And what's interesting is that the fact that the white politicians have demonized Obamacare and probably some other factors, the fact that the navigators are primarily African American in this state, has resulted in the fact that 60% of the people who got health insurance through the marketplace are black, which is an anomaly since most states they are majority white. I think probably every other state in the nation they're majority white. The thing that would be most beneficial, the ACA was viewed as a whole piece that put the health insurance in one place and Medicaid in another, and elderly people off to the side in a different place. And then the Supreme Court said that the Medicaid piece, states could make a decision about it. And Mississippi is one of those states that said, we don't want it. And therefore, a lot of people fall through the gap. There's a gap between around $4,800 for a family of 3. If you make more than that, you're not eligible for Medicaid. If you make less than $23,000 a year with that same family, you're not eligible for the subsidies for health insurance under the marketplace. So you're in a gap in which you're too rich for one thing and too poor for the other. And you don't get any health care at all. And there are at least 135,000 Mississippians that fall in that category. and a lot of those would be African American. And well, what we found is that we've been in a struggle to try and get the enhancement of Medicaid up to 138% of poverty level, which would be a wonderful boon for us. And the Black Caucus has put in yeoman's work, and we've got a few white allies, you know, but not enough to get over the top, so that we need to figure out ways to reach those white politicians who have allowed, you know, all this rhetoric that demonizes Obamacare to influence them. And I think one way may be to try and do some outreach in the white community to get more white people interested and involved in the next round of the insurance program. So that would lessen the political problem that we're having in the white community, and therefore with the white politicians. And I think that some sort of coalition building has got to take place in order to make that happen. But I think that's the next big step that has to happen, because we are going to someday, we are going to expand Medicaid. It's going to happen, but it's going to take a lot of work. We've got to put our hands to it like we did 50 years ago. We're going to have to get at it again.
Thanks, Rim. One of the reasons that I wanted Rims to start this off to sort of set the context of what we look at in terms of healthcare access specifically 50 years ago, and look at the dynamic and even the conversations we're having today about healthcare access. And so I appreciate that, Rims. What I want to do next is jump to Dr. Lewis. Dr. Lewis has a presentation that's going to sort of help to further set the context for our conversation that we're going to have with our panelists and with those in attendance today. Dr. Lewis?
Yes. Maybe I will stand. Good afternoon, everyone. Good afternoon. How are you doing? Awesome. I can't believe I'm at this podium. Okay, just take a moment. I'm so honored to be here with all of you. Thank you for being here, and I'm going to make a little bit of an announcement first. I'm working on the healthcare team for Freedom 50, and please don't forget to drink water. We've already had a couple of people get sick. We've had a couple of people get excited and not eat and fall out and have to go to the clinic and have some ambulances on standby. So we've got water for you everywhere, but talk to your friends, talk to your family. Let's stay well and healthy so we can be strong and fight these fights and win Medicaid for Mississippi and win everything. So we agreed we're going to drink water. Yes, and we got plenty of bathrooms around, so we're going to do all of that. That's what I'm talking about. Hold up your water. Yeah. All right. So I'm going to run through this presentation because I really want to get to the conversation. And this might be... Makani, I'll just ask you to flip it. Okay, so the Affordable Care Act. Keep going a little bit, keep going. That's me. I'll give you my information later. And so, as my esteemed panelist said, the Patient Protection and Affordable Care Act, otherwise known as the ACA, otherwise known as Obamacare. However, it's the law and it's here to stay. It has faced...
I think Obamacare needs an S on the end.
Obama cares,
because
they don't.
that Obama cares.
There you go. Ooh, we're gonna have a rally. All right, let's keep going. I'm a unionist, so yeah, let's rally. Okay, next slide. And so despite, 40 plus votes to repeal in the House, the Supreme Court challenge, which, left us some challenges, but actually showed us where our partners were and where we needed to do good work, so we'll organize around that. The 2012 presidential election cycle, which we won. We have our president, Barack Obama. The healthcare.gov thing, which I like to call it that because in a lot of communities of color, they weren't looking at the internet. That was a big TV kind of Washington problem that, oh my God, the internet's broken down. But, despite all of that, you name it, lions, tigers, and bears, and all this other stuff. Next slide. We still had 8 million people that signed up in marketplaces across the country. We had 3 million more people that were enrolled in Medicaid and CHIP that didn't know they were eligible for Medicaid in a lot of states. A lot of them just kind of went to the internet because they said, oh, this healthcare thing is happening, and we caught a lot of folks who didn't even know but signed up anyway. And that's just the numbers as of February. And we
May I
have,
interrupt again?
I'm sorry,
May I interrupt again?
who says no? McConaughey says no.
Okay, so we got 8 million.
Mhm.
The 3 million young adults are in addition to the 8 million?
The 3 million are in addition to the 8 million,
And
because,
we got 3 million more enrolled in Medicaid and CHIP.
yes,
So we got a total of 8 and 3 and 3 got a total of 14 million.
absolutely.
So
And these
folks
are,
who want to take Obamacare away,
I'm just saying, you see where he's going with this, guys, right?
they want to take health care away from 14 million Americans.
That should make for a great organizing moment for every single one of you. And so there are 5 million people that are enrolled in plans that meet ACA standards outside of the marketplace. So that's people who are speaking will say everything from 8 million to 10 million to 20 million. But it's millions of people who have been helped because of the law, despite all of those challenges. And so, you know, on top of that, don't worry about the last slide, McConaughey, it's fine. There are millions of people who, before the Affordable Care Act, would have been discriminated against, could not have gotten health care because of a pre-existing condition, women's care costing more than men's care, costing more because of where you live, or just because, and that's against the law now. There are children that can stay on their plans. There are all of these things that are part of the patient protection part of the Affordable Care Act that are part of the law. And so, just keep going, McConaughey, that's fine. And so, as a trade unionist, I felt the need to kind of bring in a little bit of a Philip Randolph. And I don't know if you guys have heard this quote, that at the banquet table of nature, there are no reserved seats. You get what you can take, and you keep what you can hold. If you can't take anything, you won't get anything. And if you can't hold anything, you won't keep anything. And you can't take anything without organization. How many of you have heard this quote before from A. Philip Randolph? You all know it so well. Dr. Orr is back there. So next slide. So my question to you, given that we have this landmark law with all of these accomplishments, with all of this work yet to be done in states like Mississippi around the union, many people still not getting care, and it really being civic engagement, all of the issues that we fight for, what is it that you, as organizers, what will you hold? What will we hold in the law? What will we take in terms of this moment in healthcare? Because we are far from every single person in the United States getting quality, affordable healthcare. We're far from there. But what will we take in that, and how will you organize around it? So next slide. Because, as my brother said, there's Mississippi, but there are 5.7 million people that will be uninsured in 2016 simply because the elected officials have decided it's not for their states. 5.7 million people. And if you look at the next slide, this is what the map looks like. The yellow states are the ones that have refused Medicaid, okay? The light blue ones are thinking about it, they're open to debate, but we know what that means. It's, it's the slow walk. And the dark blue are the people who are currently the people implementing Medicaid. Now, I always thought this map was interesting because it looks like a lot of maps, right? Right? Let's see the next map. This is the voter ID law map, okay? And we could put slavery, we could put so many maps on top of this. So this is all one justice fight. So your registration to vote, your economic justice, your education, all of this fits into one. But I just wanted to show you these two things. Next slide. So of course, vote. I don't have to tell people here, vote, register to vote. But I heard someone say the other day that if you vote by yourself, it's almost like a sin. Like you should be bringing other people with you always, even if it's your kids, your cousins, and my mom told me, so it used to be a family holiday, but let's, institute that all the way around. People are laughing because they know what I'm talking about. Next slide. So I wanted to take 3 issues in terms of the things that you could take, the things that you can hold, and how you can organize. And let's talk about ACA enrollment. So we did all that great work, the 8 million people in the marketplaces. And in Mississippi, that's interesting that it was 60% people of color. Because like you said, in a lot of states around the country, it's more so it was the low-hanging fruit. It was the young white male invincibles, the people we could get quickly in on their smartphones that we could, so we can get those numbers up. But a lot of communities of color got left out because that was considered the deep work or the community work. And so it's different. And so what we learned in our work at SEIU, there's 1 million healthcare workers in the union that I am so proud to serve. I see a bunch of my union brothers and sisters out here. I'm a nurse from Wisconsin, my organizers from New York. We learned the things that you all know as community organizers, that you gotta first identify the areas of greatest need. Like it's cute that we went for the low-hanging fruit just to get the big fancy numbers that we have, but we have work to do deep in the communities of the greatest need. We have to do it in the language that people speak. Don't be throwing language about deductibles and premiums if we really just need to talk about how to save your life, how to be healthy, that you can get medication, you know, or the literal Spanish, Chinese, man, you know, kind of thing. Next, in person. Next slide. And in partnership with coalitions and communities, as my brother said. Next slide. And so just to let you know, here are some facts. So this next enrollment period is a lot shorter than the first one. It's November 15th to February 15th when we're going to have open enrollment for the marketplaces, okay? And so the thing you can do, a lot of community health centers received money to try to reach out to their communities, to have events or to enroll folks in the Affordable Care Act. Reach out to your community health center and help them figure out how to have an event engaged. And so, I'll give you that information again later. You can go past this. This is slides. No, you can go past it. Keep clicking, Makani. You got this. Pictures of people signing up folks for Obamacare, right? Good stuff. The second thing we really need is there's a lot of pressure actually on workers and on communities because people they're understanding that something's changing and it's changing for working people and people of color. For a lot of us, we know that 8 million, 10 million, 12 million, 20 million folks with insurance is a great thing. But just like 50 years ago, that's good news to some folks and it's fear to others. And so what we want and we need is a system where even more people get insured, where everyone has access to Medicaid, where everyone has access to a doctor that looks and speaks and cares about them. So, next slide. Part of this pressure is we have a lot of employers around the country who are using this opportunity to say, we can't pay you because of Obamacare. You home care workers should be making less than $9 an hour because Obamacare is going to make us go away. And so we actually have, you can keep going, we have a couple of examples at Hopkins. How many of you have heard of Johns Hopkins University? One of the best hospitals, right, in the country? One of the best medical schools, the Bloomberg School of Public Health. 2,000 workers making poverty wages. Less than $11 an hour, less than $10 an hour. Thousands of workers that qualify for food stamps. And so the workers there have risen up and said, you can't be talking about health care and human rights and your mission if you're paying poverty wages. So that's one example of what's happening. And that's our local 1199, the biggest healthcare union in the country that's driving that. Next. And then home care. We know a lot of us getting older. Oh, how many people, I usually say, how many people are getting older in this room? Good, okay, still awake. But home care, it's nice to have that option. We have 500,000 home care workers in our union. Of those 500,000 home care workers, so many of them live in poverty. Less than $10 an hour, can barely make ends make, and work, crazy shifts. And so, we currently have a lot of things going on, and I actually have people who are going to pass out more information for you so that you can join in and kind of support. Because again, these workers are being exploited because people see the shift, the 8 million, see all those dollars, and they want it to go back in their pockets, not necessarily in the change we want. And they're using these opportunities to take away from our workers. So I feel like I'm getting to the end of my time, but you will definitely get those sheets, and please read them and sign them for our workers. And the next slide, Makani. So this is just all the information that I offered you, and I'm happy to give it to you after the session. But on healthcare, on the Affordable Care Act on enrollment, get informed, know the facts so you're not duped. You can always go to the phone number, get more information. You can go to healthcare.gov, it's not scary, it's fine. You can go to find a healthcare center, .HRSA.gov, to find a community center and partner and get organizations and set up community events. and get with one of our volunteers to find out more about our worker fights. So with that, I will thank you so much.
Thank you, Dr. Lewis. So what I'm going to do now is kind of start a conversation and sort of weave in everybody with some different thoughts. What I want to do is actually start with Dr. Marshall. We're here talking about minority participation in ACA, and that can mean a lot of different things. But before we get started, can you, being a retired physician who's practiced over 20 years, can you sort of speak to what does having health insurance really mean for the patients, or even for those patients who did not have health insurance, what that meant to them?
Good evening, everyone. Everybody out there. Good evening. Before I answer the question, I was just wondering, by a show of hands, how many people here live in Mississippi? Raise your hand. Great. And how many people here are from states other than Mississippi? Raise your hand. Oh, fantastic. I wanted to get in this hand raising thing here for a minute. We recently had a mayor here in Jackson who passed. His name was Chokwe Lumumba, and he was a very dynamic leader for our people. But when he was running for office, some video surfaced of speeches that he had made, because he was a freedom fighter for his people. He was an advocate for his people. So any FBI agents with videos, making videos of this session, please raise your hand. Come on, because we know that, we're being watched all the time. It's no paranoia. Recently it was discovered that all Americans' emails and telephone calls are being monitored, and America was aghast at the nerve of the government snooping on it as well. If you're of African descent in America, it's every day. It's nothing new. It's all the time. And so, how many of you all saw the movie 12 Years a Slave? Raise your hand. And I'm going to come back to 12 Years a Slave. And I think it's a movie that everybody should see. There's a lot of lessons there that people have forgotten. And the results of our enslavement here in America is still obvious to us. And no more than in health care. I think no more, there was a quote that Dr. Smith put up there that Martin Luther King said, nowhere is oppression and injustice more evident than in health care. So I'm going to come back to 12 Years a Slave, but there was a scene that I'm just going to get you all to recall, those of you that saw it, and try to describe to those of you who did not see it. But one of the slave enforcers, I think you call them crackers, had attacked the brother that was a slave, and he had strung him up, put a noose around his neck, threw the noose over the tree, and was attempting to lynch that brother, to hang that brother. And he was squirming and keep his feet on the ground. Y'all remember that? I was looking at that and my feet were squirming, trying to help the brother stay on his feet. And the brother stayed there until the slaveholder came and cut him down. It seemed like he was up there, at least 48 hours, on the plantation with that noose around his neck, squirming to stay alive. So I'm going to come back to that at the end, but I just want you all to recall that. In America, when it comes to health care, not just Mississippi, our people are second-class citizens. Our people people are second-class citizens in America, but no more place is it more evident than in healthcare. America has technology that's superior to any other country in the world when it comes to healthcare. Technical expertise, advanced development of treatment, of care, but it is not accessible to the people of America. And so it's only accessible to the rich, to the white, to the people of opportunity. And so the statistics that you see in American health reflect more what our people suffer in America. You look at Mississippi, because we're 50% of the population, don't think everybody in Mississippi is deprived of health care. But we're on the bottom because Mississippi has such a large black population. And so I practice in a rural community in Mississippi. The county that I practiced for over 25 years, not 20, over 25, had the second highest percentage of people of African descent, I call New Africans. In the United States, the second highest percentage. And we were adjacent to the county with the highest percentage. And we started out, when I came to that community in 1987, with 6 doctors. When I stopped practicing in 2011, there were 2 doctors. And we used to see patients constantly at a community health center from when the doors open until when the doors close. Constantly. I remember an episode, I was so tired one day of just seeing patient after patient after patient. It's not doable, to give good care to so many people over a short period of time, but you do what you can. And I was at the end of my rope. I just was trying to keep my composure, and see the patients that were there. I walked into the room, and I didn't have a smile on my face. I didn't have a frown, but I didn't have a smile. And there was an older man there with his son, and I walked in the door, and he said, "Are you Dr. Marshall?" And I said, "Yes, I am." He said, "You saved my daughter's life." And, the good Lord, the Spirit, Almighty sent me that patient that day, because that gave me the strength to go ahead and see the rest of the patients that I had to see that day. But the question was, access to care. Whether you have insurance or not in rural communities, your access to care is very precarious because there's so few providers, so few people that are willing to practice in those areas where there's high need, low financial compensation, and so forth. And I'm going over my time now because I could talk forever. But let me say this, last thing, getting back to 12 years of slavery. There's nobody coming to cut us down, my sisters and brothers. Nobody coming to save our lives. It is up to us to do what we need to change our condition of second-class citizenship and second-class health care in America. Politically, economically, socially, it is up to us. And we look for people of goodwill and good faith and people that love justice to be by our sides and look out for us as we attempt to better the conditions of our people. I don't know if I answered your question.
No, you're fine. You actually brought up some more questions.
Yes, sir.
So one thing is, I do want to come back about the issue around the physicians and the physician shortage. Before I get to that, I want to touch with Dr. Lewis first. You were talking about enrollment, and you talked a little bit about ACA enrollment strategies into the health insurance marketplace and into Medicaid. And as Realms pointed out, our data in Mississippi was a little different from some of the national data about who actually enrolled into these services. What are some things that you saw nationally, Dr. Lewis, around enrollment that maybe worked, and even some things that you saw that did not work, that we all can consider in the work that we do?
So that's a great question. I actually just left a conference where we discussed this. 800 people discussed this last week. I'll start with what didn't work. Pretending like it was an election. Dropping off a flyer at someone's house and saying, go to healthcare.gov and get insurance. And it didn't matter what language, what persuasion, because you're asking someone to give personal information, to sign up, to do something. In a lot of cases, they haven't. It didn't work. We spent a lot of money kind of trying to be canvassing to give information model. What did work was just basic community organizing, finding out from people what they needed and going straight to them. And a lot of times we did pre-enrollment, pre-navigator type community events. So in the south side of Chicago, we had folks that came into a community health center, to a big Salvation Army center, and we had a health fair where we brought mammogram bands from the local hospital and had healthcare workers do diabetes screenings. We had young folks come out and sing and dance. We had electeds come out and do the wave, right? And we had people talk about the basics of what is Obamacare, what is healthcare. Before you even get in to give me your identification and your tax, all of that stuff, just what is it? We started there with the what is it and why is it important for me to understand about healthcare insurance. And then we would have some navigators from the community, some people who were trained to kind of walk people through and have good deep conversation with them. That we did one event for 2 hours in the south side of Chicago, and off of that one event got 300 people signed up because they brought their families into that space and had a safe space in the community to learn, to understand, to digest the information, but to make these very critical, intimate decisions themselves. And so the money's there, but it's not rushing through it, but making sure that people have all of their questions answered and using the resources that are available.
Okay, thank you. Realms, if you've been involved with a bunch of enrollment work here in Mississippi around ACA, one of the things I wanted to ask you, do you see any parallels or differences or things we can learn from CHIP enrollment to when we sort of started trying to do outreach and get children enrolled in the CHIP program as to what we're doing around the work we're trying to get people enrolled into the marketplaces and even the Medicaid? Or even things that you've seen that work, or even things that don't work?
Well, things that work, if you're going to enroll children in Medicaid and CHIP, is go where the children are. I mean, go to the daycare centers, go to the schools, go to places like that where they may have parent meetings and talk to the parents about the benefits for their children. And that seems to work pretty effectively. Now the marketplace, I think, is a lot tougher. And I'm not quite sure what the most effective thing is. A lot of I don't know what the right numbers are, but a significant number got insurance through the marketplace because the institution that served them wanted the bill to be paid.
That was a hospital.
So they were in a hospital, and the hospital worked to get them enrolled so the hospital could get paid. Which is nice, but, that's not, covering bad debts is not what Obamacare was all about. I'm not sure I think the community health centers have a pretty good outreach program because they can offer, if you don't get on, they can still offer you healthcare services at the center on a sliding fee scale. So that's very good. I think that's probably effective also.
So one of the things I want to point out, what we heard both from Reams and Dr. Lewis in terms of what we can be doing to enroll people into the marketplaces of Medicaid is first by going to the people with this, not treating it as if everybody just automatically knows what we're talking about when we talk about health insurance and getting health care and access to care. There's a level of education that I think has to happen before even talking about enrollment. So that's one thing to sort of point out. Dr. Redditch, what I wanted to come back to, Dr. Marshall mentioned and was talking about physicians and physician shortages, and we've talked about how do we get consumers or patients enrolled in the ACA. How do we get doctors involved? Because one side you have minority participation from people and getting insurance. What about doctors sort of buying in and physicians buying into the process of ACA?
Good question. My perspective on all this, one of the things that's lost in the conversation is especially in small and rural states like we have here in Mississippi, as Dr. Marshall said, we've got a dearth of providers, both black and white, but certainly minority providers have not been trained in our state through our state's-only training program, and it's difficult to recruit people to our state for the reasons that Dr. Marshall has already said. There's never been a shortage of work. There's always been work to be done. It's difficult to find two things: people to do the work, and I think as we have in the entire country, we don't have the distribution of providers that we need. And I think the one area that people never talk about that is completely apropos with all of the struggles that we're talking about and the whys of workers and everybody else is in the area of mental health. And we are woefully inadequate in providing care as if those diseases don't exist. So, I'll tell you, the frustration is, as I said in my little quick bio, that our principal business is providing health care in jails and prisons. And we've gone to Alcorn's nursing school. Alcorn University is the only black nursing school, 4-year institution that also trains postgraduate nurses, i.e. Nurse practitioners. And we have offered them the perfect crucible for training, i.e. Our prison population, to establish a mental health nurse practitioner program. We can't get it off the ground. So I think, as we're talking about the issues associated with I won't say dumping, but in encouraging all of these people to be enrolled, whether you're talking about expanding Medicaid in Mississippi or even the healthcare exchanges and encouraging people to sign up, which we are in disproportionate numbers. But we don't have the provider source to care for these folks. We're not talking about just neurosurgeons and cardiologists or all these things. We're talking about primary care providers. We're talking about OBGYNs, psychiatrists, psychologists, family medicine physicians. I mean, there's a tremendous amount of providers that need to be trained, and not only trained, but at least you can't put hundreds of thousands of newly insured patients into the system and expect that anything in our state is going to change if there's nobody to take care of it. So, I think we've got to think about and strategize not only about getting people into the system, but somebody's got to be there to take care of them, not just in Mount Bayou or Port Gibson or any of the communities that border the Mississippi River, but even in inner cities like Jackson or any of the other inner cities across the country, they've got essentially the same issues that rural Mississippians have, and that is we don't have enough primary care providers, and we certainly don't have the breadth of disease specialists in order to impact the system in order to most efficiently care for the morbidity that exists in our community.
So you brought up a couple of things, and one thing that we haven't talked about today, this idea of when we talk about getting more minority participation from our physicians in ACA and being able to meet the need that's out there. I guess that means we need to go back and look at what we're doing in our medical schools and our healthcare training programs and making sure that we have diverse classes that are willing to go back and train in some of these places.
And not only that, I think in terms of community activists, one of the things that we've got to do is get to our young folks. The generation before me, the folks that were here, Dr. Smith, Dr. Barnes, Dr. Shirley, all of the physicians in our state and across the country who were pioneers that desegregated medicine in the South worked together. When folks like me and Dr. Marshall, I know he looks like it, he's 100 years older than me, but we were actually contemporaries because he came to medicine late. But anyway, we were not the same age, even though I've been practicing a little more than 25 years here in Mississippi. But one of the things I think, and Dr. Marshall will attest, is that we work together. And just like Renz Barber and Dr. Smith and Dr. Shirley, I mean, there was a network of like-thinking people, and we don't have that, especially with our young physicians. We don't refer to each other, we don't trust each other, and I mean, that's not just true for the medical community. It's true throughout our Black society.
And I think you're speaking to something very important. So we've both heard people talk about organizing, but we're talking about organizing on multiple levels. So we're talking about organizing physicians around this work. We're talking about organizing people and communities around this work. So let's stay there for a minute. I do want to invite, if there are questions from the audience, please feel free to chime in. I think we have a mic here. Valencia, you'll help, and I know you probably have a question as well, can help sort of navigate us with the mic as well. But still standing at that idea of organizing.
Can I add a couple things?
Sure, go ahead, please.
Sure. So I actually grew up in rural southern Illinois, a little town called Mounds, population 1,000. And I went to Queens, New York, where you'd be surprised, some people would be surprised to know that there are areas of deep need and disparity in a lot of our cities that are these, kind of underserved, not enough doctors and nurses. There are a couple of vehicles that are popping up nationally for people to collaborate. Now, I'm just going to say, first of all, one thing you can do is challenge your physician to get involved. Whether it's your physician in your church or the physician who takes care of you, tell them that you need them. It's one of the reasons why I went straight from residency into activism, because they tried to, my hospital was a underserved safety net hospital in Southeast Queens that did not have enough politics to stay open despite all of the fighting from the community, all of the work that was done and the deep need and analysis. And they say, Doc, if you can get out there and fight for us, we need you to do that. They need more doctors like us. So there's Doctors for America. That's one advocacy group that has doctors in every state, including 3 of us that are around here kind of providing health care. The National Medical Association, I mean, I push, because just like every other national organization with local affiliates, you know how this goes. If you don't get involved, it can be whatever little thing it can be. But as a trade unionist, I know that some of the best convenings we have is when we put our doctors and our nurses and our home care workers and our nursing home workers and the faith community in the same room and say, we all have a common vision, let's move forward. One other example, in New York City, there's this group called Impact, Mobilizing Preachers and Communities. And they've partaken 300 small churches. Yes, there's 300 small churches in New York. That blew my mind when I first got there. I'm like, really? I had to ask folks who live there, how are there 300 churches in New York? I'm like, walk down, anyway, let me not go down there, because they're New York folks that know what I'm talking about. But like the preachers just said, you know what? Once a month from the pulpit, we're going to talk about healthcare. And once a month, we'll have a healthcare provider, nurse, doctor, to come in and talk about what resources are available and the ACA. That's a simple thing you can do. But I would say there are opportunities here, and there's a lot more I can say about stuff in the ACA, about training more doctors and how we're going to have a nurse shortage and how we're going to have all these other things. But it really goes back to kind of getting the information, getting in there, and providing this fire, this wind that makes us take down what we voted for and what's ours.
Dr. Marshall, would you want to speak to this sort of organizing and even getting physicians involved in, or even getting community involved in?
Yeah, as was just said, that's what makes the difference, is organizing of the community. Frontline physician, I mean, you can see patients all day, and you can burn out all day. But if the community is not organized, if the healthcare system is not organized to serve the people, then nothing's going to happen. It can't be based on an individual. It has to be based on a system of healthcare. And that includes healthcare providers and people that use healthcare services, which we all do. I think one of the issues that troubles me, Dr. Reddick kind of alluded to it, was this generation coming up that don't have a social commitment, that don't have a commitment to serve the underserved. And that is very troubling. That is very detrimental to the health of underserved communities. And so all these issues can be addressed by people organizing, organizing around healthcare, organizing around political issues, it's organizing. I mean, that's the answer to this.
So, and again, question?
Well, just to Dr. Marshall, if I remember 12 Years a Slave, particularly, the man who was hanging from the tree, there were people behind him
Exactly.
walking by and paying no attention. I wanted to say, look, do something.
That's
Is
my
that
point.
correct?
That was my point. I didn't address it specifically enough, but they were waiting on someone else to take care of the problem.
They were afraid.
Yeah,
and they just
they were
didn't do
afraid
it.
to address it. And they had been conditioned to think that it was beyond their power, that it was someone else that could save them. And yes, thank you very much.
And I want to bring up too, because I see some young people in the audience too, and I think I'm part of this generation that you and Dr. Rex, I'm 33 myself, so I think I'm. And they,
We're talking about you.
okay, so they're talking about my generation. So you sort of prescribe the problem, or there's an issue. What are some things that we can do to bridge those gaps? Because we've seen how when we organize together, how we work together, when people are talking together, we see what can happen, what good can come from that. So what are some things that we can do? Our generation, if it's your generation, can take ownership on to making sure that we're very purposeful about those communications and sort of building this and addressing these issues around healthcare.
I think one of the things that we all need to do a better job of is communicating with our elected officials to make sure that they understand what the real issues are. It's not as if any of our leaders, elected leaders, come to us to ask our opinion. Just as Brother Barber said earlier, if you have a question, you go to the people you're trying to help to get their opinion on what is the help that you need. So I think that's one of the things that we need to do a better job of doing. And I think I'm not sure how to better engage our young folks, especially our black males, to get them excited about helping other people. And between the social media and drugs and we don't know how to talk to. They don't know how to talk to each other. It's kind of difficult, to relate to folks who they don't know how to relate to anybody for all intent and purpose. And so we need, to re-engage on the collegiate level, on the grade school level, on how to talk, how to communicate with people, what your problems are, how to write those ideas out, and not use the internet to do all of your homework. You got to get out into the world to see things in real life for yourself, to understand how to make the mousetrap better. Which is the thing we're talking about. And I think with when it comes to how are we going to take care of hundreds of thousands in our state and millions across the country of new people who have this insurance card that, for all intent and purpose, says that I have access to care, but there's nobody to take care of them. We can't do it under the same system of care that we currently have. So that has got to change. We don't know how that will look. Innovation is what we do in America, and I think innovation will occur, and I think young people will be the ticket to finding it.
So it kind of seems, if I'm pulling what you're saying right and pulling it together, it seems that one place how we bridge that communication between the generations is identifying those issues and trying to come up with solutions through innovative sort of intergenerational ways. Okay, this question in the back too. As he's coming, did you want to speak to something afterwards?
Yeah, I do actually, and I appreciate the comments there. I'm actually very hopeful, especially at this conference, that we do have an intergenerational approach. I wanted to give 2 examples of some of the good things that are going on with young black men and with students. And just, in the spirit of Ella Baker and what we're trying to do here, we in our 30s, 40s, 50s, 60s, we have to... 20s, rock on, thank you, 20s, young 20s.
You're talking about your daughter now.
I'm just saying, this is being taped, right? This is being taped, okay, y'all got that. How much we create the space and bring people with us, to show them, it's not just the book and the studying about it, it's how to be, how to eat, how to survive. Because a lot of students today are starting their careers with $100,000, $200,000, $300,000 in debt, which is completely different. With families that don't have the home wealth because of the market crisis, that don't have the deep pensions because of what's going on with unions. So it's a different set of survival things that's going on. I don't know if you saw this doctor that snuck in here, gave some water, and then snuck out. He's Dr. Tom Ellison, who runs Project Help in Alabama. He is serious about making sure he always has young folks, med students, residents, elementary learning, taking responsibility, understanding, because there is a hunger you're given. There's a specific genius in every child, and if you open up and give an opportunity, they're there. We have young black men that have walked over to our volunteer tent, have learned about what's going on with home care workers, and are walking around with sign-up sheets right now. One of the main reasons this conference is here is because at the March on Washington anniversary last year, the group from Florida, who were figuring out how to organize around what happened with Trayvon Martin, got together with Bob Moses and the SNCC veterans and said, we need to organize. So there is a lot that's going on out there, and if we keep that space open and commit to feeding and sharing and resourcing and taking care of our youth, we will do better. The last thing I'm gonna say, I got so excited at this same event in South Side of Chicago because there was this black man navigator, name was Larry, and he said this was the first event in 6 months where I've seen young black men come in to get health care. He did an event himself called I'm gonna get a brother covered, okay? Get a brother covered. And he had young black, I'm getting chills thinking about it, he had young black men, and you know what's been going on in Chicago. And these young black men had stories of their friends getting killed and them being out of work for 2 and 3 years. And he brought in mentoring, he brought in food, he brought in job counseling and education, and he talked about how to sign up for health care. And so those are the things we could do in the spaces we create for our youth so that we're not labeling them as lost and uncommitted. There's a lot going on, but we who are a few steps ahead should be, creating the space and home.
I'm gonna get this question in here.
I just wanted to say thank you guys, first of all, for what you guys are doing and this opportunity. My name's Gary. I'm from California. I'm a 721 union member, but I'm also an organizer in the healthcare field. I organize for a nonprofit called St. John's Will Child Family Center. Right now we have over 13 clinics open in our community, and we're opening school-based clinics because we found out that due to the budget cut, the nurses were only available on certain days at certain schools. So we put 2 and 2 together. If a student has an ear infection or a toothache, how's that child is going to learn if he have to wait for the nurse to see the nurse on a Wednesday and he's hurting on Tuesday? So we started launching school-based programs, first going through the politicians and getting the backing from them with the union. And I just wanted to say, I'm an organizer, and one of the main things I do in my community is I held meetings like this. Meetings like this I held with the community twice a month. In those meetings, I bring new information that may occur from the ACA that most members don't know about. We have members in the community who don't watch TV, who don't watch the news. So I'm their advocate to bring them up on laws that may be approaching to strike down budget cuts. So what I do is we have an action committee. I teach people in my community ways to fight back. Everything from letter writing, phone banking, getting on a bus heading to Sacramento, letting them know about their assembly member in their district. That's how we have to win this and take it back. That's to start from the bottom, and we got to get the people involved because we can't do it all by ourselves. And they're not just going to listen to us. But I'll tell you what, when I showed up to Sacramento with 2 bus loads, they was listening to me. They was listening to them. And testimonial stories is the key to this. You have to have somebody come and tell a real story. I took a young lady up there and I put her in a room with her assembly member. There have been budget cuts. She said, this program helped me and my husband. He had diabetes. We couldn't afford the medication. We didn't know what to do. We found out about this program. His prescriptions were paid for. Now he's more healthier. Now he's back working, contributing to the community. So testimonial stories is the key to this, because if they don't see a face, you can tell a story, but if they don't see the face with the story or the horror with the story, they just go home and continue business as usual. So those are the key things that I'm doing to keep the fight alive and engage it in the community. And thank you guys.
Thank you.
All right.
I think I saw another question down. Is there another question down front somewhere? There you go. Awesome.
I just wanted to, from my understanding, each state has a right to set their own rules and regulations when it comes to ACA.
Well, it's 2 components. So one is Medicaid expansion. Each state has an option to expand Medicaid. So each state has that option. So a state like Mississippi, our state legislature would have to pass a bill in order for the state to expand Medicaid.
Then you get the governor to sign it.
And they get the governor to sign it. Yeah. But as it relates to the marketplace, the health insurance marketplace, each state had an option to run a state-based marketplace on themselves or you can have a federal marketplace that was run by the federal government. So there were options, but I think maybe one of the big things was whether or not states decided to expand their Medicaid program or not.
Does one need to have a checking account in order to sign up for ACA?
No.
So how does one sign up and then it has to be paid automatically?
Federal marketplace, you would go to healthcare.gov to enroll. If it was a state-based marketplace, they had some type of state website. In addition to going through the website, there was a toll-free number that you could call, and there were organizations throughout the state, throughout that state, who were funded, who could go out and help people enroll into the marketplace, or people could go to community health centers. So there are multiple ways to enroll. Well, any other questions? Because I want to get the docs in on that, because I think what you're mentioning is a potential way to, I think, maybe expand that healthcare force, whether by finding other mid-level providers, where it's practitioners, physician assistants, which we have a physician assistant program here now in Mississippi, to expand that healthcare force. Would you all, either of you all like to speak to that at all?
As I said earlier, I mean, one of the things that we in medicine will have to do is change the way that medicine is currently being practiced, which means that by definition, every member of the team is going to have a maximal level of participation, restricted only by their license and what that will entail. I think that's the only way that the system is going to work in the future. And we're, one of the things that's good about providing care in jails and prisons is that we don't have the constraints of third-party reimbursement. We get a capitated rate to provide care, and the issue is what's the most efficient way to provide that care. So assuring that that every person that is participating is maxed out on their license capabilities is the obviously most efficient way of providing it. And just as an aside, we're talking about the ACA or universal health care coverage, which is ultimately what we are striving for. But prisoners in this country, whether you're talking about a county jail or state prison or a federal prison, are the only groups in the country that have a constitutional right to health care. The government has to provide it at the community standard of care, period. So the answer to your question is they are going to have to be more active participants on the team. We're ultimately responsible. We've got to sign one of the reasons we write so badly is because we sign our name so frequently. And the most important thing that we have to have is total trust in all of our team members, not so much knowing what they know, but being comfortable with what they don't know. Mm-hmm. And that's true for all physicians, I mean, anybody on the team. So the system will change, and all those folks are going to be maxed out on their capabilities. And so it's not going to be an issue going forward as it has been heretofore.
Question?
Yeah. I'm Dr. Buzz Graham. I'm a primary care physician in Northern California. I just wanted to address a little bit about provider shortage. I think that everyone in the panel knows, and probably in the room, that there's a shortage problem. I grew up in Beverly Hills, California, and we had no problem with getting physicians there. And the other is the disparity between specialists and primary care doctors. And I could spend a lot of time, and I'm sure people up there, why primary care is at the bottom of the birdcage in terms of physician practices. So I think there are some efforts now on the national level to try and address, which is a fairly complicated issue. And of course, as you know, if you grew up in a rural area, you're more likely to go back to a rural area. If you grew up in an urban area, there's virtually no chance that you're going to end up practicing in a rural area. The other thing is, in terms of using other types of healthcare workers, there's a very innovative clinic in Las Vegas that primarily relies on healthcare coaches. And I spend a lot of time in my day trying to get people to stop smoking, do more exercise, eat better, all of these type of things, which I'm not sure I really do that well. And these are people that are employed that are really focusing on these type of lifestyle issues to try and get people to make these changes. And it's not necessarily something that a physician or a nurse practitioner really has to do. Maybe someone could actually do it better if they're a little bit more thoughtful. So I think that part of the solution to this is to really look at new ways of providing care where the physician is really working at the top of his license, dealing with things that really he's trained to do, and getting people to focus on some of the other areas that maybe someone else could do better.
It creates business opportunities. So where are minorities as it relates to maximizing the opportunities? So for example, when you think about the need and focus on preventative care and the payment structure and financing structure around healthcare, that creates opportunities for community health educators, community health workers. That could potentially be new jobs. To create health educators for the public health people who can help around chronic disease, to do the smoking cessation type of work, to do these things. So it does create opportunities to engage people on different business levels. So if someone could, maybe Dr. Reddick, I know we've talked about this before, speak to, from even the standpoint of minority participation and examining ACA even for business opportunities as well.
Without question, the payer ultimately is the ultimate consumer. And I think, one of the things that we all have to factor into the equation is one of we're now forced into documenting our practice in the electronic health record, which is a huge industry that was created under the guise that it would make medicine more efficient. And I think any practitioner who's engaged in electronic health record will tell you that you're no more than 8% as efficient as you were before the electronic health record came. So we're forcing people, providers, to spend more time doing things other than healthcare. Getting back to your question, though, the main thing, and getting back to your point of opportunity with these healthcare coaches, I mean, the consumer is the next one that's going to be impacted on, like smokers, being overweight. I mean, all of the things that, cheating if you're diabetic, and A1Cs are inordinately elevated because of your lifestyle. Ultimately, because of the way that we're documenting everything, more responsibility is going to be placed on the patient, on the consumer, and I get those little bit mixed up between not the payer, but the patient, and I think there will be opportunity associated with that, because their cost of insurance is going to be commensurate with their lifestyle issues. And if you don't change your lifestyle, you cannot change your ultimate health outcomes. So your morbidity is going to be directly commensurate with the severity of your lifestyle deviation. So I think, ultimately, as payers, as the insurance companies and the government look at the variables and the individuals, you're going to pay, just like you do now for life insurance. If you pay a lot more if you're a smoker. You pay a lot more if you engage in skydiving or scuba diving. I mean, all of those things are ultimately, if your weight is up, if you're a smoker, if you're all of these things, you're going to pay more, and you'll be forced on a different level to do things differently, and I think that will create additional opportunities for people.
In 2008, I volunteered with Obama's Elevate campaign as my first introduction to this, like the nascent discussion of the Affordable Care Act, or what became that act, a single payer system, or other alternatives. Is that still an option? And if so, how do we advocate for that without undermining the Affordable Care Act now?
A lot of people in this room and in the country were saying single payer is where we need to go. We need to get as a physician, I had in Queens, I had 26 different plans I had to figure out for each patient. Pain in my butt. But that didn't even get it. Ooh, I'm in the church. Okay. But single payer. And then we went to public option, and then we got to the ACA, and now we're right. And so the question was, is single payer still a viable option?
What is single payer?
Is it
Canadian style, John.
Medicare for all? I like that. Universal health care, Medicare for all versus the different plans. And how can we talk about that in a way without undermining the ACA?
Yeah.
So I like to use Martin Luther King's quote about the moral arc of the universe is long, but it bends towards justice. And even if we look at where we are now, 50 years from Freedom Summer, and how much we're still having to fight for voting rights, one of my kind of really, big concerns about, we still have a lot of people in this country who do not believe they deserve to be healthy. That, that they have to earn the right to see a good doctor. We have a lot of community organizing around ourselves to do about healthcare, what is possible in this country, what exists everywhere else. What the doctor was saying about our own response. We have a lot of work to do there. So I would say, this is one step, making a good public health system, building up community health workers, doing our work in terms of education, empowering our communities. We may be looking at a 50-year, 100-year arc towards Medicare for all, 100%, but if you look at the other justice arcs we're talking about here, I think that's been the way that myself, Bill Lucy, who I believe is speaking in kind of trade unionist space, he's been around for years talking about justice in different ways, that we have talked to folks about saying, look, it is the same fight, it's a long fight. We're not talking about single payer tomorrow, but we do know this is one step on the way to go. And to that end, can we be clear that we've got data and we've got studies of the wazoo that shows that investing in communities and prevention and good food and exercise, all of that stuff is better outcomes. We know that. The politics of healthcare right now are not going to do anything we're talking about for our communities, including paying the good doctors, who see people in our communities. That's what healthcare equity is. It's freedom and justice. So just know that we're fighting here, and this is part of the fight.
I have one other
I would say
question.
engage in fixing it. We know what happened. They put a lot of standards and didn't give them any money. Just like they did with education. Put a lot of standards and don't give them any money. And people don't stand up till stuff is rolled downhill. But I'm just saying, let's build.
That all this attack on the VA is going on for precisely the reason that you're stating, that they're attacking the VA because it's the only government medical care system that we have. And they want to make it look bad so that nobody will want one.
No
and
question.
Medicare is also
Medicare,
a
right.
national health system, single payer, and it works pretty well.
No argument. But all I'm saying is the public persona of what a single payer is this is just not the time. We need to get to the bottom, understand what happened, and not demonize the whole system, but work towards fixing it, and then it can be replicated.
I have a question from the audience as well.
We have been a group that has been informing the community, our local community, and 10-county area actually, about the Affordable Care Act. So we're having, for anyone in this room who may be a navigator or involved in that type of work, we're having a debrief session to go over some of these same issues and look at what to do next, what have we learned, what lessons have we learned from the last enrollment period. And that's going to be this Friday at the Mississippi Library Commission from 10 to 2. So it's free, open to the public, you're welcome to come. I have several hats to wear. I'm a transplant to Mississippi, I'm a physician, I'm also a consumer of the Affordable Care Act. I'm a recent return back to college student. I'm a mother, grandmother, a new grandmother. So I have lots of hats, and I think I have a lot of different ways and perspective of looking at this situation. I'm a big proponent of the Affordable Care Act, and anyone who knows me knows that I am, because I will say so. And I think there's a lot of politics. It's all about money. You know, it's a lot of greed. Healthcare is a big business. You know, disability and death is a big business. And so in Mississippi, it's a big business. It's also about power and control. And in Mississippi, in my opinion, it is all about turf wars, money, and greed. And so several things that we addressed and that I've learned from being in Mississippi over the last 21 years, when I speak if I tell my patients, you know, hey, the Affordable Care Act, it's here, let me explain it to you. If I make a stance, they see me make a stance that I stand with the Affordable Care Act. Not trying to repeal it, not trying to make it like it's going away. If I'm confusing them, and if I'm confused, they're going to be confused. So this state confuses its citizens because they don't stand up for what they believe in. Now, either they don't believe in it, or they do. So if you believe in something, you stand up for it. If your patients see you stand up for it, then they're going to get information from you. You're going to give them correct information, otherwise they're going to be misinformed or uninformed. That's my own individual perspective. Second thing is, most of the medical societies are apolitical, so they say, okay, in our state. But our state medical is not apolitical. It is political. It has its own way of handling its politics. So we either have to be political or be apolitical. And say we're apolitical, you know, we have no opinion. But if you're apolitical, then how are you going to move your state forward? How can you be an activist if you're apolitical? And this has been a conversation over history. I mean, you know, for communities of color, we cannot afford to be apolitical. What does that mean? Politics is life. Life is health and education. You know, they're all connected. You cannot separate them out. You can only be apolitical if you just don't want to address the issues in public. So you either choose to do that or you choose not to. But your public will be misinformed. If you want your public informed, then you will help to get them informed. And I don't have a problem with that. So the people who disagree, who don't like the Affordable Care Act, that's their side of the story and their opinion. I stand for it or with it, and I don't mind amending it or improving it or whatever needs to be done, but I make a stance one side or the other. There is no in-between for me on the Affordable Care Act. So I believe it values our residents, and so I don't have a problem with same thing with Medicaid expansion. So what I see from my patients is that they are so confused because they're so misinformed, because they're getting their information from elsewhere and from politicians and from people who don't say anything. Because the medical community also doesn't say anything to the patients or to the community. Or they say it under a guise, you know, where the health fair will say something. But they don't make a stance for it. As Dr. Lewis, you don't have, when you listen to her, there is no if and or buts. You know where she stands. So, you know, her patients know where she stands. So, you know, there's a lot of trust issues, particularly in Mississippi. There's a lot of trust issues in communities of color, and it's not without a reason. So we have to be able to build a trust with our patients in order for them to also trust us to give them the correct information. It's a two-way street. Capacity building, building that relationship, building trust, dialogue, or whatever name you want to give to it, it's ancient ages old. And in order to get things accomplished, that is activism, that is community activism, short and simple. So there's many ways, whether it's old methods of just one-on-one communication or, you know, massive community activism, innovation out there in the community or social media or whatever, however you want to do it. But there's plenty of ways to get that done, and everybody can have a role to play. Back to the politicians in the state of Mississippi, from what I've learned is, yes, we do have a two-tiered system. We always have, we always will. So our politicians are informed about the Affordable Care Act. Oh yeah, they know. They know what it is, they know what it does, they got their information. So they then come back to the state of Mississippi, in my opinion, and use their information in order to create the outcomes or the state which they want to see. So they don't want to expand Medicaid expansion. But whose responsibility is it to make them? It's the public's responsibility, and who is that? That includes the doctors. The doctors have to be saying, you know, the patients push the doctors push the legislators. It's not the other way around. They're not coming to us to get the information, they already have the information. So they're going to use the information the way they choose to use it. But we can press them to make them make a stance one way or the other. And we can press them and vote them out eventually. You know, there's lots of ways to do that. But we have to make the stand. We have to commitment, like Dr. Reddick said. We have to be committed. But what are we going to be committed to? Are we going to play the gray zone because we make money in this field and we're worried about our reimbursement rates? You know, they use that to try to repeal Obamacare. You know, let's tack it to reimbursement rates and try to get it appealed that way. You know, what are we going to stand for? What are we going to take? What are we going to hold? What do we believe in? What are we passionate about? Do we even care about our patients and our citizens? You know, yes, doctors, we work hard. We work very hard. We pay a lot of money to get the degree that we have, to get to the point where we are. But we are also love to take care of our patients, and we don't like to see our patients with disabilities, death, premature death, and, you know, dying. So, but what if we worked with our patients to back something that might help our patients, then maybe our patients will help us to be able then to work better, more efficient, and we might actually be able to improve and bring more opportunities to the state so other physicians from elsewhere, because no, we cannot do this alone and in a vacuum. In the 60s, they didn't do it alone and in a vacuum. So then we have other people who then say, oh, I can come to this state now, because they're not going to come here and work here in this situation. They're just not. Okay? Until we do something ourselves, get unified or whatever, however we choose to do it, however we want it, whatever we want it to look like, but until we create the state or the outcomes that we want and make sure people know this is what we want, however we get it done, you know, let's just do it.
We definitely, you can sit there. So we're a few minutes over, so we're going to wrap up. What I'd like to first do is thank the panel for this discussion.